In this section, we will discuss American College of Cardiology, American Heart Association guideline for permanent pacing. They divide the classification into Class 1, Class 2, and Class 3. For Class 1, it means the evidence or general agreement that a given procedure or treatment is beneficial, useful, and effective. For Class 2, they divide 2A and 2B. 2A means the evidence or opinion is in favor of usefulness or efficacy, whereas Class 2B means the evidence is actually less well established. And Class 3, it means that the procedure or treatment actually is not useful or not effective, and in some cases may be harmful. Again, when the evidence concerned, the level A, level B, or level C evidence. For level A evidence is the best. It's the data derived from multiple randomized clinical trials involving a large number of patients. For level B evidence, it means the data derived from a limited number of trials. And for level C, the data mainly, large study data, is mainly a consensus of expert opinion was the primary source of recommendation. Let's look at pacing in sinus node dysfunction, the indication. For the Class 1 indication, if the patient with sinus node dysfunction and documented symptomatic bradycardia, then it's a Class 1 indication. And this sinus node dysfunction with documented symptomatic bradycardia is very important. And it may be a consequence of essential long-term drug therapy for which there's no alternative. And in patients with symptomatic chronotropic incompetence, this is also a Class 1 indication. For the Class 2A, if a patient with sinus node dysfunction with heart rate less than 40 beats per minute, developing spontaneously or as a result of drug therapy, when a clear association between significant symptoms consistent with bradycardia and natural presence of bradycardia not documented, then it's a Class 2A. And if a patient with syncope of unexplained origin, when major abnormality of sinus function are discovered or provoked in EP studies, this is also a Class 2A indication. For Class 2B, if a patient with sinus node dysfunction and minimally symptomatic, and the chronic heart rate is less than 40 beats per minute while awake, it will classify as Class 2B indications. Of course, in patients with asymptomatic, patient with sinus dysfunction, or in patients with symptoms suggesting bradycardia are clearly documented not to be associated with slow heart rate, or the symptomatic bradycardia are due to non-essential drug therapy, then all these are Class 3 indications. That is, pacing is not indicated. Let's look at the pacing for acquired AV block. For the Class 1 indication, if the patient is third degree or advanced second degree AV block at any anatomical level with bradycardia or symptom, arrhythmia and other medical conditions requiring drugs that result in symptomatic bradycardia, or there are documented asystole more than or equal to 3 seconds, or the escape rate is less than 40 beats per minute in a awake or symptom-free patient, or if there's a post-AV junction ablation, or the post-operative AV block not expected to resolve after cardiac surgery, or in a patient with neuromuscular disease with AV block, no matter symptomatic or not, they're all Class 1 indication. And in second-degree AV block, regardless of the type and site of the block, if there's associated symptomatic bradycardia, it is a Class 1 indication for pacing. There are a number of Class 2A indications, including the asymptomatic third-degree AV block, the awake ventricular rate more than 40 beats per minute, especially if cardiomegaly or airway dysfunction is present. Again, asymptomatic type 2 second-degree AV block is a Class 2A indication, and asymptomatic type 1 second-degree AV block at intra or infrahison level at EP study, again, is a Class 2A indication. And in patients with first-degree or second-degree AV block with symptoms similar to the pacemaker syndrome, is also classified as class 2A indication. For class 2B indication, if there's a marked first-degree AV block and patient with airway dysfunction and heart failure, in whom a shorter AV interval may result in hemodynamic improvement, then it's class 2B indication. And neuromuscular disease with any degree of AV block with or without symptom is also a class 2B indication. There are a number of class 3 indications that is where pace is not indicated. In patients with asymptomatic first-degree AV block, asymptomatic second-degree AV block at supraorchestral level, or AV block expected to resolve and unlikely to recur. For example, if due to drug toxicity or during hypoxia and sleep apnea syndrome, etc., all these are class 3 indication. Finally, let's look at the chronic bi- or trivascular block. If the patient has intermittent third-degree AV block, or type 2 second-degree AV block, or alternating bundle branch block, then it's a class 1 indication for pacing. There are a number of class 2A indications where syncope is not demonstrated to be due to AV block when other likely causes have been excluded, for example, specifically VT. An incidental finding at EP study of markedly prolonged H3 interval is also a class 2A indication. An incidental finding at EP study of pacing-induced inflation block that is not physiological is also classified as class 2A indication in pacing for chronic bi- and trivascular block. For class 2B, if a patient with neuromuscular disease with any degree of vesicular block with or without symptoms is still a class 2B indication, because in these circumstances, there may be unpredictable progression of AV nodal conduction disease. There are a number of class 3 indications in patients without AV block or symptom, or just first-degree AV block without symptom. They are all not indicated for pacing.